Hello, thank you for having me to this forum. I think it's great to see people interested in this topic, and I wanted to start by telling you a little bit about myself. I'm a junior faculty member here. I've been in San Francisco for 4 years and previously came from Philadelphia, which is where I did most of my training. Yeah, absolutely. So I've been at UCSF for about 4 years, and I'm a clinical faculty member. I did most of my medical training in Philadelphia and then was hired here, and I see patients, and I also do clinical research, which focuses on looking at quality of life and functional status, and also at older patients with blood disorders. So that's sort of a background about my work. I want to start also by saying that, some of this material may be too basic for some people, and it may potentially be too advanced for others, and it was very hard to kind of gauge, what level we should be talking at. So please, I'm happy to take questions during the talk. I will sort of pause regularly for questions as well. And I apologize if some of it's too basic, but I want to make sure we're all on the same page. So, and I wanted to begin by talking about a story about how I became interested in science and how I became interested in medicine. It was during high school, and this is what I was learning about in my biology class. So we were learning about the cell and how the cell works, and we learned that DNA is a molecule looks like that. It's called a double helix molecule with 2 strands that intertwine, and that lives in the nucleus of the cell, and then the cell uses that as a template to make something called RNA, which is a related molecule, which is like a transcript, and it's like a message saying we need to make this protein that this gene is encoding. And the mRNA leaves the nucleus and goes into the cytoplasm, or the main part of the cell, and then it goes to the ribosome, and the ribosome is a part of the cell that takes that transcript, that mRNA message, M stands for message, and makes a protein. And proteins are what do everything in the cell. So this is a picture straight out of our biology textbook. And what's really going on is that the DNA molecule consists of a backbone residue. This is the backbone chemical structure, and it has 4 types of molecules attached to it that are represented by the letters C, A, T, and G. And those are the only 4 letters that make up the entire genome. C, A, T, and G. And when the messenger RNA gets made, the mRNA, it basically sort of makes a mirror image of the coding strand of DNA, although it's a little bit funny because basically C always binds to G and A always binds to U. So, but it essentially, without getting into too many details, it makes a copy of this message. And then when the mRNA gets to the ribosome in the cytoplasm, the ribosome reads it in pairs of 3. So it takes the first 3 letters that it sees, and it says those 3 letters correspond to a particular amino acid, which is the building block of protein. And then it looks at the next 3 letters, and it says, okay, that's this amino acid, et cetera, et cetera. And it takes things in chunks of 3, and each 3 of these letters stands for a specific amino acid. And when it puts all these amino acids together, you get a protein. And again, this was sort of what we were learning about in my high school biology class. And this is pretty cool, I thought, but I was also interested in English and math and other things. Now, the issue, though, is that when you get a mutation, and we're going to talk a lot about different mutations, but one type of mutation is called a point mutation. And what happens is that in this example, the U, when the mRNA is made, instead of having a U at that little spot right there, it makes a mistake and it puts an A. And the problem with that is that GUU stands for valine, but GAU stands for aspartic acid. So when that mRNA gets to the ribosome is going to put the wrong amino acid in that spot where the valine is supposed to be. And sometimes that has no consequence at all. And the protein that gets made functions totally normally, But other times that can cause very significant problems for the protein function, and that protein doesn't work well. So that's and one example of a mutation called a point mutation, because it just happens at that specific point. So we, in high school biology class, had to do a project about inherited genetic disorder. We had to pick an inherited disorder and do some research about it. And I chose to look at Huntington disease, which I don't know if anybody's familiar with, but it's a progressive neurologic disorder. Typically, it has its onset in people who are in their 30s, and it's gradually progressive over 10 to 20 years until the person actually dies. And this is an inherited disorder, meaning that if you have a parent with this disorder, you have a 50% chance of getting it. Unfortunately, there's no treatment for the disorder, and there's no cure for the disorder. So it's a pretty devastating disease that affects young people in the prime of their life, and it was something that I was interested in learning more about. So I went to the biomedical library at the city that I was living in, and I found a paper describing the discovery of the mutation that causes Huntington's, the gene that causes Huntington's. And this is what I found. And I just remember sitting there in this library, kind of jaw dropped, staring at this and going, well, first of all, I have really no idea what to make of that. It was just so cut and dried and black and white, and there it was in front of me. And the part that you need to pay attention to is this. I've just blown up that first top part right there. And in this gene, there's a repeat here of the CAG, 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 CAG. And the amino acid that stands for is Q. Q, 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 Q. And normally in all of our bodies, it is normal to have less than or equal to 24 CAG repeats, 24 Qs. And what happens in Huntington's, as it turns out, is that it's like the ribosome stutters, and it just keeps putting, or the gene stutters, and it keeps putting more CAGs, more CAGs, and more CAGs. And people can get up to 48, up to double or even more CAG repeats. And this causes an abnormal protein that is encoded for by that gene. And we don't yet understand how that causes Huntington disease, but we know that this is the gene. And when I looked at this and I said, in black and white, this is what is causing all these people to have such a devastating disease, it really struck a chord with me and inspired me to want to know more about how the cells work and how these chemical events can cause so much devastation in people's lives, and to try to help that and to try to develop treatments and to develop cures. So I went to college and all that stuff, and medical school, et cetera, and here we are. Okay, so this is an overview of my talk, and I'm going to do a little bit of review of normal hematopoiesis or normal blood development. And I know you've recently heard a couple of lectures about this, and so some of this will just serve as review. And if you have any questions that are remaining from that, I'm happy to try to field them at this point. And then we'll talk about bone marrow failure syndromes, a couple of different types of bone marrow failure syndromes, acute leukemias, a few selected types, and then we'll talk at the end about stem cell transplant, which is an area that I do a lot of clinically. So we'll start with hematopoiesis. So what I tell patients is that in all of your bones, in the inside of your bones, there's a liquid space called the bone marrow, and that is where blood is made. And making blood starts with a hematopoietic stem cell, which is a cell up here that is capable not only of regenerating itself, but also of generating all of the cells that make up blood. And there are a lot of cells that make up blood, and not only make up blood, but make up your immune system. So the first thing that happens is that this cell turns into what's called a myeloid progenitor, and all these cells are called myeloid cells. And then a lymphoid progenitor, and these are all called lymphoid cells. And then each one gradually develops along these various developmental pathways in it, and they make all these different cells that normally live in your blood and serve different functions. And I'm going to be focusing on diseases that affect the hematopoietic stem cell, and also on the myeloblast. So more to come on those cell types. And just to review, when we're looking at blood clinically, we order what's called the CBC, which stands for complete blood count. And we get three main parameters out of that. We get the red blood cell count, the platelet count, and the white count. So here's the red cells. That's them. And here's the platelets. That's another thing we count. And then all of those other cells are the white cells. And numerically, there are a lot more red cells and platelets than white cells, orders of magnitude more. And so it's sort of, you can kind of get a sense that the red blood cells and the platelets are kind of just, they're all one and the same, they're doing their job, and they all have the same job, but the white cells are very diverse. And they serve a lot of different functions, and they go to a lot of different places in the body, and they can result in a lot of different diseases when they go awry. I'm going to pause and ask if there are any questions at this point. Okay, great. Okay, so we'll start talking about bone marrow failure syndromes. And I want to point out that aplastic anemia is one kind of acquired bone marrow failure syndrome. Can't speak tonight. And we're going to also talk about two forms of inherited bone marrow failure syndromes, which are Fanconi's anemia and Dyskeratosis congenita. And I'm going to probably abbreviate those FA and DC. So just so you know. Okay, so we'll talk about aplastic anemia in general first. So aplastic literally means failure to develop. That's what that word means. But aplastic anemia is really a misnomer because it's really not anemia at all. And this actually takes a long time for people to learn during medical training. People always think, oh, it's anemia, but it's actually not anemia at all. It's a failure of the bone marrow to make enough cells of all three lineages. So it's basically a failure to make blood. When people have aplastic anemia, they are not making blood cells. And another name for this disorder is called the empty marrow. There's virtually no cells there. And what we know about aplastic anemia is that it is a disorder of the bone marrow stem cell, the hematopoietic stem cell. Clinically, aplastic anemia is a rare disease. So there are fewer than 5 cases per million people per year. So if you took 1 million people and followed them for a year, less than 5 of them would develop aplastic anemia. That's quite rare. And clinically, their presentation is based on the deficiency of each of the cell lines that they're not making enough of. And you can sort of reason through, by knowing the function of these cells, what things they may experience. So when people have low white blood cells, their main job is to fight infection, broadly speaking. And so these people get infections, and they get fevers. When you have low red blood cells, that's called anemia. And the main job of the red blood cell is to carry oxygen and give you energy. So people are tired. They appear pale. They may be short of breath because as they walk around, they don't have enough red cells to carry the oxygen to their tissues. When people have low platelets' job is to promote clotting. So when your platelets are low, you bleed and you bruise more easily. How do we make the diagnosis of it? Go ahead.
Any age relation?
It can occur in any age. This is one of the diseases that can occur in young patients, and there is an effect of age on prognosis, which I'm going to talk about. So in making the diagnosis of aplastic anemia, we need to look at the bone marrow. And I think you may have heard a little bit about how a bone marrow biopsy is performed. I did not include any pictures of it because it's a little bit gruesome, but essentially what we do is we take a hollow bored needle and we anesthetize the local area, which is usually done in the back of the hip, and we push the needle into the bone, and then we remove it, and there's a little chunk of bone that's inside that needle that we look at. It's a procedure that probably has a worse reputation than it merits, but certainly it's not one that anyone would want to have. So when we look in the bone marrow, what we normally see schematically shown here are the blood-forming cells and also fat, because fat is actually stored in the bone marrow. So these are fat cells. And histologically, what you see here are these pink areas in here are all the developing blood cells. These white areas are fat. And then this is stroma, which is sort of the supportive tissue in the bone marrow that basically just supports the blood cells as they're being made. But in aplastic anemia, you basically see all fat. Maybe a little bit of cell development here and here and here, but basically you see the stromal tissue and then fat. It's basically empty. So,
Question.
yeah.
That area of the bone marrow that you said nourishes the blood cells, what do you mean by that? It
Yeah.
provides it with different chemicals or what?
It's actually, when I say support, I mean that actually in a physical sense. It's really just sort of like providing the connective tissue, providing some kind of physical structure for the cells to sort of sit on. It's not involved in the blood supply. So the bone marrow does have a blood supply, and that is where like the nutrients that the cells need to develop is coming from.
Okay, thank you.
Yeah, go ahead.
Do fat people have more fat in their marrow?
No, they don't. Fat people have more fat in the typical places you expect people to have fat. Yeah, and actually, you can actually take 100 minus a person's age, and that will give you a rough estimate of how cellular a bone marrow should be. So bone marrow becomes less cellular as we age. So for a 20-year-old, their bone marrow should be approximately 80% cellular, but for an 80-year-old, their bone marrow should be approximately 20% cellular. Aplastic anemia has a lot of different potential causes. It can be caused by exposure to certain chemicals, and in particular, one of the ones that's more notorious is pesticide exposure. There are a lot of different types of medications that can be associated with aplastic anemia. So when we see a patient with aplastic anemia, we always take a very careful medication history to try to get at whether any recent antibiotics or other medications could be responsible. Certain viruses are known to be associated with aplastic anemia. Hepatitis viruses, the HIV virus, and another virus called parvovirus is also associated. Radiation, whether intentional or not, can also cause aplastic anemia. And then there are certain patients with aplastic anemia that have an inherited predisposition to develop the disease, which we're going to talk about next. But the majority of people who have aplastic anemia, the cause is unknown. And we call that idiopathic. We don't know what caused this disease. What we know pathophysiologically about idiopathic aplastic anemia is that it's an autoimmune disease. So normally in your body you have these cells called T cells, T lymphocytes. And one of their jobs is to distinguish what is yourself from what is foreign. And so they're involved as part of your immune system in attacking viruses and other infections that your body needs to get rid of. But in certain autoimmune diseases where something goes wrong with the T cells, they can see your body's own tissues as foreign and attack them. And type 1 diabetes is an example of an autoimmune disease. Lupus and rheumatoid arthritis are other examples of autoimmune diseases where the problem is something is going wrong with the T cell and it is seeing the body's own tissues as foreign. And so in aplastic anemia, the patient's own T cells is attacking the bone marrow stem cell. That hematopoietic stem cell that is responsible for making all of the blood is being attacked by the body's own T cells. And so the treatment of aplastic anemia, ironically, patients have no immune system. The treatment is actually to suppress the immune system. And I guess what you can take from that is that even though we say they have no immune system, they must have a little bit of one because it's attacking itself. I don't know if that was going to be your question.
Well, sort of the balance. I mean, it's attacking its own progenitor, so.
That's right. And T cells do live for a long time once they're made. So maybe that some of these T cells just have a long longevity, but it is true that it is, in some sense, a paradox. How can if there's no immune system, then how can there be an immune system to cause this problem in the first place?
Well, what percentage of the stem cells produce T lymphocytes?
All. So every stem cell produces every cell that's part of the immune system. One of my
I was wondering about what the relative amounts are.
So in the body, there are a lot more red cells and platelets than there are all of these white cells combined. So relatively speaking, right, that this stem cell is making many fewer T cells than it is making red cells. Absolutely. So again, although it's sort of ironic, the treatment for this bad blood disease is to give more medicine to suppress the immune system and try to fight this bad T cell. So how do we fight T cells? So one of the mainstays of treatment is a medicine called ATG, which stands for anti-thymocyte globulin. So anti is against, thymocyte is a T cell, and globulin is an antibody. So basically this name is saying that this is an antibody against a T cell. How do we get an antibody against a T cell? Well, it turns out that we take human T cells that have been purified and they're injected into an animal, either a horse or a rabbit. And because these animals have their own immune system that are designed to recognize other things as foreign, these animals make antibodies against these human T cells. Here's that antibody. And then we actually purify that antibody out of the animal and package it and give it to people. It's a little bit crazy. Patients always are surprised that, yes, this medicine came from a horse, came from a rabbit, but this is how the medicine is made.
Are these T cell suppressor or helper?
That's a good question. I don't think we know exactly. I think it's still, the pathophysiology is still being studied. So we use this medicine, ATG. We also use another anti-T cell medicine called cyclosporin, or a related medicine called tacrolimus. And sometimes we use stem cell transplant, which I'm going to talk about at the end of the talk. And I think just to address your earlier question, whether we use this immune suppressive treatment or whether we use stem cell transplant is a big debate in every patient's case. And in general, patients who are younger with aplastic anemia, and by younger I mean the youngest category is less than 6, and then the next category up is like 6 to 18, so we're really talking about kids. Those patients tend to do well regardless of what therapy they get, but they do better with transplant if it's from a sibling donor, and we're going to talk more about that. So in general, if a sibling donor is available for a young patient, we would prefer to do a stem cell transplant using a sibling donor. But where a donor is not available, or in an older patient where outcomes with transplant are not as good, then we tend to use the immune suppressive treatment as first-line treatment and reserve transplant if that immune suppression does not work.
Question. Okay, so sometimes this is caused by chemicals and medications and viruses and radiation. Does your body attack those things? I mean, your immune system attack those things, or do those things cause autoimmunity or both?
So typically, if you were exposed to a virus, typically, right, your body would fight the virus. Depending on which virus it is, sometimes you can just get rid of it. Other times it tends to hang around chronically. And we don't know the mechanism for how those viruses cause aplastic anemia may be different than the mechanism in this sort of autoimmune aplastic anemia. So it may actually be different pathophysiologic mechanisms going on. But yes, your body would try to, if you're, for example, if you're exposed to a medication, your body would just clear the medication. And some people don't get aplastic anemia. Most people don't. And we don't know why some people do. And it's probably something to do with their immune system and how their immune system sees that molecule, that drug molecule, but we don't understand why some people get it and some people don't.
So once you've got it, this is lifelong, you take this?
Um,
Once you get a transplant?
Right. So the immune suppression, if you have a response to the immune suppression and your blood counts recover, then the goal is to gradually taper the immune suppression with the hopes that the disease does not come back, but it can come back. And there are certainly people that need to be retreated with immune suppression, particularly if they've had a long response to the original course. So for example, they're relapsing 10 years later, you might try immune suppression again, and it's a single course of immune suppression. So you get the treatment, you have a response, and then you gradually taper the medicine to off.
So that would imply that your body, if it gets a chance, you still probably still got some T cells that are going wacky, but your body's able to then
Exactly.
get enough a chance to keep under control.
Exactly, right. Now with stem cell transplant, you are replacing your immune system with a new immune system. Nonetheless, transplants aren't perfect. They don't always work, and so people can relapse after transplant as well. None of these treatments are, as with anything in medicine, none of these treatments are perfect.
Does the cause ever determine the treatment?
Absolutely. So, for example, when a medication is the cause, sometimes if you withdraw the offending medication, blood counts can recover spontaneously. If there's a virus, treating the virus, if you got active virus going on, treating the virus can make the counts recover. And so we like to find a cause because we hope that we can aim our treatment at that cause. But even when we do this, there are certainly people where their bone marrow does not recover even after the medication is removed or even after the virus is treated.
Right. Those treatments are before these treatments.
Correct.
So is this treatment ever dependent upon the cause? Once you've treated the virus, taken away the causing medication, then would one of these treatments?
No, I would use either immune suppression or stem cell transplant based on factors like the age of the patient and the availability of the donor more than what was the cause. Yeah.
Do you have any way of telling if the abnormality is in the stem cell or it happens after it started to form the T cell?
No, we think the abnormality is a problem with the stem cell itself. Yeah. Okay, I'm going to keep going. So I'm going to talk next about a disease called Fanconi anemia. Fanconi anemia is an inherited genetic disease, and patients with it have aplastic anemia. They also have an increased susceptibility to leukemia. They are susceptible to other cancers, a variety of other cancers, and they can have other physical abnormalities that I've listed here. And we think of these sort of rare genetic disorders as being, clearly identifiable based on these abnormalities that you can easily see when you look at somebody. But in fact, only 60% of people with this disorder will actually manifest with a physical abnormality, and 40% have no physical abnormality at all. So it's not always obvious when you're seeing a patient with aplastic anemia whether they have Fanconi's anemia underlying or not. And although the mean age of diagnosis is 6, as an adult oncologist, I do still see some of these patients because some of them are in their 20s and 30s when they're diagnosed, although less commonly. So people have tried to figure out, well, what is the gene that causes Fanconi anemia? And they've looked at large studies of large families where, multiple siblings, and they've looked at inheritance patterns and tried to study the DNA of these family members to identify genes that have been mutated in these families. And they have come up over the many, many years with this long list of at least 13 genes now that have been implicated in Fanconi anemia. So a mutation in any one of these genes can cause the disorder. And these genes are, if you look at what chromosome they're on in the cell, they're all on different chromosomes, and they don't seem to be physically related to each other. And so the question is, well, how are all these genes related? How are all these different genes causing the same disorder, which is a Fanconi's anemia? And it turns out that when people have looked at the function of these genes are all involved in repairing DNA. So by way of background, I'm going to talk a little bit about DNA damage. So in our cells, we are always having DNA damage as a result of a lot of different things, just regular metabolism, exposure to light, exposure to the regular radiation like you would get from flying in an airplane, or even just from ambient radiation from the sun sitting on the earth, chemical exposures, and just regular errors in replicating the DNA. And so all of these things cause DNA damage, and it's estimated that there can be up to 1 million damage events per cell per day. That's a lot of problems. And so the cell has to have some way of dealing with these problems. And what it does is it says cell cycle checkpoint activation. It says, hey, wait, I should stop dividing because there's something wrong with my DNA. Let me figure this out. And then it says, hey, I should activate some of my genes that are involved in fixing these problems. So let me turn on some genes and turn off some other genes to help me do this. And I should also fix these problems. The cell has specific programs of repair, specific enzymes that are involved in repairing different types of mutations. And ultimately, apoptosis, which is basically a controlled cell death. So the cell says, if I can't fix all these mistakes, I should die because there's something wrong with me in that, and I shouldn't make more of myself. So we're going to...
There's a question.
Yeah.
Is all of this intelligence in each one of the cells, or is it somewhere else in the bone marrow?
It's in
Who's making these decisions?
the cell. The cell.
The cell.
The cell.
Each cell.
Each cell.
That's incredible.
Yeah. Yeah. So I'm going to talk a little bit about DNA repair. So one of the kinds of errors that can happen in DNA is something called the DNA cross-link. So when you have these two strands of the double helix, and here's the A and the T and the C and the G, they're bound together, they're held together lightly by a sort of loose chemical bond. And one of the things that can happen is you can get this thing called a cross-link, which is a tight chemical bond. So the two strands of DNA are physically bound together and they can't separate. And the problem is that the strands need to separate in order to replicate themselves. That's part of the cell cycle. The strands have to come apart, and then a copy gets made of this one, and a copy gets made of that one, and that's how you end up with two strands of DNA from one strand of DNA. So if the DNA can't come apart, that's a really big problem. So the cell has to have a way to fix that. And it turns out that the way to fix a DNA cross-link is actually very complicated. Basically, enzymes have to come in and break apart these strands and break apart that strand. And here's this loose DNA strand hanging out that's supposed to be attached here, but it's not. And then these guys copy each other, and it's a lot. It's a lot of hand waving, but it's very complicated, and it involves a lot of different proteins. The cell has to activate a lot of different proteins to make this kind of repair happen, and this is happening all the time. So you can imagine that without these proteins, the cell would be in really big trouble because it can't repair this DNA cross-link. So it turns out that these proteins are the proteins that are made by these genes. So to follow this through, if the cell has a mutation in one of these genes so that one of these proteins doesn't work properly, the cell can't repair its DNA, and it has a really big problem. And it leads to chromosomal instability, it leads to more mutations being generated, and it basically can lead to developmental abnormalities, cancer, and organ failure, like aplastic anemia. We don't totally understand why those particular organs are affected and not other organs, but what's very clear is that all these genes, all the genes that have been found to be associated with aplastic anemia, are involved in the process of DNA repair. So we can say that Fanconi's anemia is a disorder of DNA repair.
Are some of the mutations more severe than others?
Absolutely. So it turns out that it depends. If you have a mutation in this one, for example, that may tend to have what we call a higher penetrance, where you are more likely to actually have the manifestations. In some of these genes, they have a lower penetrance, which means that you may or may not be physically affected maybe earlier or later in life. So yes, there are clinical differences in the different mutations.
And it's all the cross-link repair, also the cross-link repair.
Correct. Yeah. So we can actually use this knowledge that we have about the pathophysiology to develop a diagnostic test for Fanconi's anemia. So what we do is we take blood lymphocytes and they're cultured with a chemical that causes DNA crosslinks. So this is MMC's mitomycin C. That's actually a chemotherapy agent. And DEB is diapoxybutane, which is just another chemical. And these chemicals cause crosslinks in DNA. And you can see that these chromosomes, once they're exposed to these chemicals, look really funny. They've got these funny crosslinks here where they're stuck together and they don't look linear like they should. And so when you see this pattern, that is diagnostic of Fanconi's anemia. Normal cells, when exposed to these chemicals, can repair this damage, but Fanconi's anemia lymphocytes cannot. Okay, I'm going to move on to the next inherited syndrome, which is Dyskeratosis congenita. So this is very analogous to Fanconi's anemia. So this is another disorder. It's inherited. Patients can have aplastic anemia. They also have multiple other cancer types. They're particularly susceptible to lung fibrosis, so scarring in the lung, and also cirrhosis of the liver. And they also have certain physical abnormalities that are characteristic of the disorder. And about 75% of people with this disorder have some physical abnormality, but again, 25% of people don't. So again, when somebody's coming in with a new diagnosis of aplastic anemia, how do you know that whether they do or don't have this underlying disorder? And again, the mean age of diagnosis is 14 years, but some people are diagnosed up until their 50s and 60s. I actually have a patient that I diagnosed in her 30s, and she said, oh, and I was asking her about her family history and said, oh, my father has low platelets too. I don't really know, but I'll get you the card for his hematologist. So got me the card, and it was one of my colleagues sitting at the desk next to me who was treating her father for low platelets and saying, oh, we don't know what the cause is, but, we'll figure it out. And I said, I know what the cause is. So again, Dyskeratosis congenita, there are these large families and people have looked at them, and here's this list of genes that have been shown to be associated with Dyskeratosis congenita. And the question is, what do these genes have in common? The same way as aplastic anemia.
Are the genes that cause the blood abnormality different than those that cause the physical abnormality?
Same gene. All these patients have one mutation in one gene, and it's causing all the abnormalities they have. These are just different. So for example, one family might have this gene mutated, another family might have that gene mutated, but within one family, it's always, and within one individual, it's always the same gene. So what it turns out is that all these genes have to do with something called telomeres. I'm going to back up and talk about telomeres for a second. So here's a chromosome, and at the end of each chromosome, there's something called a telomere. And what a telomere consists of is a bunch of repeats, kind of similar to that Huntington's gene where there was that CAG repeat. But this is a TTA-GGG repeat. And the ends of chromosomes have hundreds of thousands of these repeats. And then these sequences are not actually encoding anything. They're basically just serving a structural function at the end of a chromosome. But they're not encoding a gene, they're just there. And then what happens at the end of the chromosome is even kind of funnier, which is that these two strands separate. So the red strand comes up here and the pink strand goes down here. They come back together over here. Then they loop around, and then at the very, very end of the chromosome, one strand is actually longer than the other. And this longer strand actually goes into the hole and binds here. So this is actually basically the DNA forming a knot at the end of the chromosome, which I think is pretty cool. I don't know. So, and then this structure is stabilized by these complex of proteins. This complex is called shelterin, and it's made of a bunch of different proteins. So why do we have these things called telomeres? These are very conserved structures, which means that all organisms have these structures. It's not just humans. Yeast have these. Everybody with a chromosome has these structures at the ends of chromosomes. So what are they for? They must be really important if everybody has them. So it turns out that due to some of the physical properties of DNA replicating itself, every time a cell divides, a very small amount of DNA gets lost at the very end of the chromosome, every time a cell divides. And it's not very much for every one division, but if you think about how many times a cell divides over the course of days to a year, that's a lot of cell division, that's a lot of information in that DNA that's being lost. And if we didn't have telomeres, then coding genetic material would get lost.
The bacteria have telomeres, don't they have circular DNA?
So, right, so plasmids don't, but anybody who has a chromosome, sorry. Anybody? Yeah. So we don't want to lose genetic material. So teleologically, what the cell has done is put these telomeres at the ends of the chromosomes so that they act as martyrs, and they basically prevent coding genetic material from being lost, and instead, telomeres get lost instead. So as the cell divides and divides and divides, the telomeres get shorter and shorter and shorter and shorter. And so if you look at this graph, on the y-axis is the length of the telomere in thousands of base pairs. So a base pair is a letter, so thousands of letters. So that means that in cord blood, when a baby is born, that the telomere is approximately 11,000 letters. And then over the course of the lifetime, telomeres get shorter and shorter, and by age 90, it's 6,000 letters. So 5,000 letters have been lost. Now, actually, it's a lot more than that. If you really think about how many times a cell divides over the course of a lifetime, it would actually be a lot more than that were lost. And it turns out that these bases are not only being lost, but there's an enzyme whose job it is to maintain these telomeres and make them longer. And that enzyme is called telomerase. And its job is to maintain those telomeres, to make them longer. And it consists of this enzyme called TERT. It's got an RNA template, a template molecule that encodes for that TTAGGG, that it wants to add more of those back on, and then some other proteins over here. Just a little plug. Elizabeth Blackburn, who works at UCSF, got a Nobel Prize for the co-discovery of telomerase and of telomeres in general. So go UCSF. We're proud.
Is there any difference in telomerase and stem cells, cancer cells, and normal cells?
That's a great question, and really a question that is the subject of active scientific investigation. Telomerase, people are studying telomerase. People want to know about what would cells do if they had more telomerase, if they have less telomerase, how can we regulate the activity of telomerase, what functions does it serve in the different cell types. I think it might be hard to answer that question concisely in this format. We can talk more about it after, but it's a subject of active investigation. So what happens as the telomeres get shorter in a cell? So as the telomeres get shorter, if you can imagine that the chromosomes are getting shorter and shorter, and there are more free ends, so more cells that don't have enough telomere on them. And in the presence of regular protective mechanisms, so the cell can sense this. It says, hey, my telomeres are too short. I'm going to die because this is a problem. I need to have telomeres. But if those protective mechanisms don't exist or something else happens to the cell, the chromosomes become unstable. They can actually fuse end to end, and that results in translocation, so movement of some chromosomal material from one chromosome to another, and it can also result in loss of chromosomes or aneuploidy. And these are all basically like precancerous lesions. So telomeres get shorter during the normal physiologic process of aging. And people believe that the telomeres and telomerase may underlie a lot of the processes that we consider to be normal physiologic aging. People are actually trying to look at, like I said, giving more telomerase and trying to immortalize cells. And there's a lot of sort of pop literature out there about, can we make ourselves immortal if we just all have lots of telomerase?
Does this account for the higher incidence of cancer as you get older?
It may, exactly. Or certainly it may be one factor.
I've seen sources saying that excess telomerase increases rates of cancer too. Is that true?
So, right, and it is a two-way street, because if you think about it, taking a cell and making it immortalized so that cell isn't going to die, what if that cell develops another mutation? And then you've got a cell that has a bad mutation and is also not going to die because it is bypassing the normal checkpoints that would normally have gotten rid of that cell because it had that mutation. So, right, we don't know if giving more telomerase could make things good. I guess it would make it good for healthy cells, but for a precancerous cell, that would be bad.
Are there any other reasons other than getting older, like a disease that causes loss of telomerase?
Well, so we're going to talk about that. Yeah, Dyskeratosis congenita. Yeah.
So how does a cancer cell's telomerase work? Is it abnormal? Is there something going on because the cancer cell's immortal? Is it doing something with this telomerase?
That's what we're trying. So I think probably in certain cancers or in certain individuals, they may be predisposed to cancer because they have something wrong with their telomerase, and I'm going to get to that. Yeah. So, so in addition to normal physiologic decreases in telomere length as a result of aging and just cell division, if you have a telomerase mutation, you might get prematurely shortened chromosomes, and you can almost think of that as like premature aging of the cell. And so as it turns out, here are these genes again that have been identified in patients with Dyskeratosis congenita, and these genes make these proteins that both protect and maintain the length of our telomeres. So what we now understand is that Dyskeratosis congenita is a disorder of telomere length, and people with Dyskeratosis congenita have mutations in these genes that cause these proteins not to function properly, so the telomeres get too short, and that leads to organ function like aplastic anemia, liver and lung problems, and also leads to developmental abnormalities and susceptibility to cancer. And then this was going to be as an aside, but I think we've kind of addressed this a little bit, that a lot of times in medicine we study rare diseases in order to learn about the cell's biologic processes and provide insight into the pathophysiology of what's happening in either the sporadic form of the disease or in terms of biology in general. And I think what we are now coming to understand is that there are some mutations in these proteins that have a high genetic penetrance, which means that they, in and of themselves, will cause this disease. And they require very little input from the environment in order to do so. So these are the people that we see in clinic, the young people with aplastic anemia and these physical abnormalities. But there are probably other mutations in these genes that have a lower genetic penetrance, meaning they don't really typically do that much by themselves, but they can almost be thought of as a risk factor to develop organ failure, and they require more input from the environment. So it may be that in some people, for example, who smoke, some people who smoke don't get lung fibrosis, but some people do. And it may be that some of the people who do got it because they already had a genetic risk factor, which was some abnormality in their telomerase system. Similarly with alcohol, some people who drink a lot of alcohol never get cirrhosis. Some people do. Maybe those people have something going on with their telomerase system. And similarly for aplastic anemia, It may be that some of the people who we thought of as being idiopathic, or who we thought of as having being associated with a virus or a toxin, why do some people who are exposed to that virus, that toxin, get aplastic anemia and others don't? It may be that some people had this inherited predisposition, and all it took was an additional environmental insult for them to develop the full-blown disease. So really, there's mutations. There's more to be discovered, and they're on a spectrum, and we think that they probably affect a lot more individuals than we currently are aware of. Again, just sort of one last slide about Dyskeratosis congenita. We can use what we know about telomeres to design a diagnostic test for the disease. Basically, we measure telomere length. It's pretty straightforward. And we have a sense of what the normal length should be, and we show that people with DC, who are shown here in red, have telomeres that are too short than would be expected for their age, and it is age adjusted. So I've talked a lot about bone marrow failure syndromes, and I guess, I want to sort of close this section by saying, well, what does it really matter? Does it really matter if somebody has Fanconi's anemia or not? If they don't have these other physical abnormalities and they don't have these other cancers and they just have aplastic anemia, does it really matter? And it turns out that it does matter. It turns out to matter quite a bit. The way we treat these disorders is that, when the patients have aplastic anemia, we can do a stem cell transplant, but we know that that only fixes the bone marrow problem. Doesn't fix the fact that they have Dyskeratosis congenita or Fanconi's anemia in every cell in their body. And so they're still predisposed to developing the other cancers and the other issues that these patients can have. And so when they do develop other cancers, we essentially treat them as we would anybody else who had that cancer, depending on the cancer type. But the problem is that chemotherapy is a DNA cross-linking agent, and it damages DNA. And so people who have Fanconi's anemia in particular, but also Dyskeratosis congenita, are very sensitive to the side effects of the chemotherapy because their cells cannot recover from the damage that the chemotherapy is doing to every cell in the body. And so we really, not only do we have to have intensive screening programs to be able to detect these cancers early in the patients who we know are at risk, but we also have to have unique treatment programs, including unique stem cell transplant regimens that are less toxic. If you were to take a patient with Fanconi's anemia and give them a typical treatment, it would be fatal uniformly. So they really have to have unique regimens designed for them, and that is why we care whether somebody has this or doesn't. Okay, I'm going to pause and see if there's any questions about this section in particular. Okay. I'm going to talk about leukemias next. And in particular, I'm going to talk about two forms of leukemia: acute myeloid leukemia, or AML, and acute promyelocytic leukemia, or APL. And there's a lot of different kinds of leukemias, and these are just the ones that I think are kind of have some interesting things to say for this group. So I mentioned earlier that we were going to be talking about this myeloblast. So, and this is the cell that is the problem in acute myeloid leukemia. So it's not a stem cell disorder. It turns out that it's a disorder of this cell called the myeloblast. And I'm going to just show another slide that's going to show in a little more detail the way a myeloblast turns into a neutrophil. And this is actually the most common type of mature white blood cell. This is an immature cell. So here's the development. So a myeloblast turns into a promyelocyte, and then a myelocyte, et cetera, and eventually becomes a neutrophil. And you can think of a myeloblast as a baby white blood cell, and this is an adult white blood cell. And so in your bone marrow, you basically have these cells at all stages of development. You got the babies, the toddlers, the little kids, the teenagers, and the grown-ups. And histologically, this is a picture of normal bone marrow, and you can see that that's a blast, so a baby, and then that is probably a band, which is probably a teenager, and then that one is a mature neutrophil, or an adult white blood cell. And normally in your bone marrow, you should have less than 5% blasts. So having some of them is normal. You're supposed to have some babies around, just probably less than 5% is normal. But the problem is that in acute myeloid leukemia, something goes wrong with this myeloblast. And it starts producing more and more and more of itself, and these cells don't mature into normal cells, normal mature white blood cells the way they should. So you just get all these myeloblasts. And this is analogous to having a bone marrow that's just filled with babies. No toddlers, no teenagers, no adults, just babies. And when you look at the bone marrow, histologically you see this sort of uniform population where all of these are baby white blood cells, and that's most of what you see. You don't see a lot of other normal cells. And that is AML, or acute myeloid leukemia. AML is the most common acute leukemia in adults. Chronic lymphocytic leukemia is actually more common. Leukemias are classified as acute and chronic. Acute means they have a fast onset and they're relatively aggressive and they present aggressively. And chronic leukemias tend to be more indolent and sometimes can be discovered incidentally, and generally the clinical course plays out over a longer period of time. AML is rare. There are about 3 to 5 cases per 100,000 people per year. Still contrast that with aplastic anemia, which was less than 5 cases per million per year. So this is tenfold more common than aplastic anemia. And the clinical presentation of AML, again, can be inferred a little bit from just having low blood counts, because when these babies grow in the bone marrow, the regular cells don't get made, and so you don't have typically enough mature white blood cells. You get infections, you're anemic, and so you're fatigued and maybe short of breath, and you have low platelets, so you're prone to bleeding and clotting. AML can also present with something called leukostasis, or sludging, because the blasts that proliferate in the bone marrow can spill out from the bone marrow into the blood, and they essentially can make the blood too thick because there's so many of them, and they can clog up some of these small arteries and cause problems in the different organs depending on where they're clogging. Typically affects the brain and the lungs. These leukemic cells, once they get out into the bloodstream too, can also infiltrate other tissues. So they can just get into other organs, and in particular, they can infiltrate the lungs. They can infiltrate the spinal fluid that surrounds the brain and spinal cord, and they can also infiltrate in other kind of unusual places like the gums. Yeah?
So they don't only suppress other white blood cells, but because the numbers, they also suppress the platelets and red blood cells as well, therefore more typical anemia.
Correct. So people typically present with anemia and thrombocytopenia, which is low platelets. And then their white count can either be low, normal, or high. And there can be blasts in the blood seen, or not. If the white count is high, it's usually because there's blasts there. But there's not a lot of normal cells.
So at what level do you normally get the sludging?
It's a good question. So a typical white count in a normal person is approximately between 4 to 10,000 cells per microliter, but 4 to 10 is the number. And certain types of leukemia, and there are subsets of acute myeloid leukemia, and certain types are more prone to causing that sludging than others. Certainly you can see it when the white count starts to get to around 50, 50. You know, we start to get very nervous at that number, and certainly above 100. And we have patients where they can present even above 200. So that, you know, people can have a lot of cells.
Can you use heparin to kind of slow down, decrease the sludgy?
Right. So yeah, and it turns out that you can't, because what heparin does is to work on the proteins in the blood that are part of the clotting cascade. But the way that these cells cause sludging is through a different mechanism, so heparin doesn't affect that. You can basically think of these cells as being sticky, and they sort of stick to each other and they stick to the vessel wall through other protein-protein interactions that don't have anything to do with heparin. And in fact, these people tend to have low platelets, and so the risk of heparin would be that you would worsen the chance of bleeding. Right. Sorry, I really can't see, so yell out if there's any questions.
So that assume that it's like high blood pressure and other stuff because of the sludge?
Actually, the sludging is happening in the very small blood vessels, and it's not necessarily happening in every organ. So the blood pressure is not typically affected, although if it affects the brain, that can affect blood pressure through other mechanisms. But no, not typically associated with high blood pressure. And so just to the pathologic definition of AML, we say somebody has AML when they have more than 20% blasts or baby white blood cells in the bone marrow. And so again, if less than 5% is normal and greater than 20% is leukemia, what about the between 5 to 20%? And that's something called myelodysplastic syndrome, which is abbreviated MDS. This used to be known as a pre-leukemic condition because it sort of is a precursor to acute leukemia, and it can turn into leukemia, although we now know that it is a cancer in and of itself. And so many of you may be familiar with Robin Roberts, who had treatment for breast cancer and then developed myelodysplastic syndrome. That's been in the news a lot. She had a stem cell transplant. The causes of AML and MDS are largely unknown. There are some risk factors, though, including prior chemotherapy. So again, in Robin Roberts' case, she did have chemotherapy for breast cancer, and that was the cause of her developing myelodysplastic syndrome. Prior radiation is another risk factor. There are certain rare chemical exposures that can be associated, and then there are certain rare genetic disorders that can also be associated. But for the most part, we're faced with having to tell patients that this is unfortunately just bad luck, and we really don't know why you have this disease. When someone is diagnosed with a disease, we try to subclassify the AML. There are a lot of different types of AML. And the reason we do that is that it helps us predict prognosis and also tailor therapy. So the first way that we try to subclassify the disease is we look at the chromosomes in the leukemia cells themselves. So just to be clear, this is not something that is inherited from parent to child, but we're looking at genetic or chromosomal abnormalities that are occurring only in the leukemia cells themselves and not in the other cells in the body. And there are certain abnormalities that are associated with an overall favorable prognosis. There are some that are associated with an intermediate prognosis, and then some that are associated with a worse prognosis. But if you look at this graph where the y-axis is the number of patients who are alive, and the x-axis is their years after diagnosis, you can see that even in the favorable risk group, if you look out to 4, 8, and 12 years after diagnosis, we're only getting a cure rate of about 50% in this graph. And obviously, adverse risk disease is much worse. So really, very few people, unfortunately, are able to survive this disease. It is a very, very difficult disease to treat. So we're always trying to come up with new therapies. One of the ways that we've been able to risk stratify people better in the last sort of decade or so is to also look for molecular abnormalities, so to look for specific mutations that are occurring at the gene level rather than at the chromosome level. So these are basically saying that there's a structural abnormality with the chromosome, and this is basically saying there's a point mutation or a smaller mutation. And so we look for these abnormalities to be able to refine somebody's risk category. And so, for example, patients with an 821 translocation where the chromosome, part of chromosome 8 becomes attached to part of chromosome 21, we typically consider that to be a favorable risk, but what we know that is that when we can find something called a c-KIT mutation or a mutation in the c-KIT gene, those patients actually transition from a good prognosis category to a bad prognosis category. Similarly, a lot of people have normal cytogenetics. We can't find any chromosomal abnormalities. And there are certain mutations where if we find them, we now know that that is associated with a better risk. And then similarly, if we find this mutation, we can take somebody who has normal cytogenetics from intermediate, again, to unfavorable risk. So we're using both structural chromosomal changes and molecular changes to best define somebody's risk of dying of their disease. And we use that to try to tailor therapy. This is a very busy slide that I put up just to show that there's a lot of heterogeneity. And that even with, this is a pie chart of patients with normal cytogenetic AML, so no structural chromosomal abnormalities. and looking at the different mutations and looking at different combinations of mutations. For example, this mutation is good, except if it's in concert with that mutation, then it's bad. And so there's a lot of different groups, and we're learning a lot about how to risk stratify patients. So how do we treat patients?
Can I ask a question?
Yeah.
Do you look at their chromosomes with an electron microscope?
No. So the way we detect these translocations is basically to grow the cells in culture in a lab called a cytogenetics lab, where this is what they do. And they are able to then look at individual cells, and it's kind of mind-blowing, but they line up the chromosomes. They're able to visually line up the chromosomes and look at them. And the cytogeneticists are able to tell that the banding pattern, they put dyes on them basically, and they're able to tell that the banding pattern is not normal. And they're able to identify the banding pattern from chromosome, 8, and notice that it's attached to chromosome 21. When I look at the report from the pathologist, I can't tell. I mean, it's a very, very skilled technique and requires a good cytogeneticist to do. So there is definitely quality. There can be issues of quality in terms of getting good cytogenetic study done.
Question. How do leukemia cells interact with normal cells?
I'm not sure. Do you mean, can you clarify a little bit?
Do they infect, are they passing genetic material back and forth and then changing those cells in a negative way?
No, they're not. They're not affecting the normal cells in the body. They're pretty much replicating machines. They basically just make more and more and more of themselves. And they're not really trying, when they do infiltrate organs, it's not that they're trying to do something to those organs. They just have homing for those organs. White blood cells are naturally equipped with homing abilities because they're supposed to go to all the different tissues of your body and attack infection or help heal a wound or do whatever they need to do. So it's just that regular homing mechanism gone awry. Okay, so how do we treat AML?
Question.
Okay.
Metastatic disease is caused by this homing mechanism going awry?
So,
is that the case?
yeah, and blood cancers are different than normal cancers, like breast cancer or lung cancer, in that we don't really use the term metastatic disease because the bone marrow is everywhere in your body. I mean, every bone has bone marrow, and your blood is everywhere in your body. And so when you have leukemia, in general, you don't really have it localized to one part of your body, and therefore you can't really say that it's sort of spread to some other part of your body. When it's in your blood or your bone marrow, it's there. And the homing process that I was referring to really just refers to whether the cells are infiltrating other organs, which happens in a minority of patients. I mean, that's not the typical presentation, but it can present that way. All right. So the first phase of treating AML is called induction, and there's 2 phases. And the goal of induction is to reduce the number of leukemia cells in the body by orders of magnitude. There's been studies showing that when someone is diagnosed, they have 10 to the 12 leukemia cells in their body, and induction aims to get that number down to 10 to the 9 leukemia cells in the body. And when we get it down to that level, when we look in the bone marrow, we can't see any leukemia. We call that remission. Remission is when you look in the bone marrow and you can't see any leukemia, and all you can see are normal cells. And we get people into remission by giving them chemotherapy. But I tell patients, we know that remission is like a needle in a haystack. Just because you can't see it, it doesn't mean it isn't there. And in fact, I just told you that, in fact, it's more than a needle. It's 10 to the 9 leukemia cells that are probably still left. And so we have to get rid of that needle in a haystack in order to cure the patient. And some of these patients are cured of their disease, so that's our goal in every patient. So the second phase of treatment is called consolidation. And the goal of consolidation is to get rid of every single last leukemia cell in the body. And when that happens, we call it cure. And the way we get to cure is either more chemotherapy or stem cell transplant. And that is a decision that is made in large part based on their risk category. So if they're favorable risk in general, we tend to use chemotherapy, whereas particularly if they're unfavorable risk, we tend to use stem cell transplant. And what we do for the intermediate risk group is extremely controversial, and if you see 10 different doctors, you'll get 10 different answers at the moment. Okay, I'm going to talk briefly about APL. So just to come back, here's this normal development of a myeloblast into a neutrophil. You've got all the different baby and up to adult white blood cells. But APL is actually not a problem with the myeloblast, it's a problem with the promyelocyte. So a slightly different cell, different disease. And here, again, the body, something goes wrong with this promyelocyte, and it starts making more and more and more of itself, and less of everything else that's supposed to be made. And the analogy is that here you've got lots of toddlers. So I'm not sure which is worse, more toddlers or more babies, but
You would know.
yeah, I won't say. So we've got lots of toddlers, and again, when you look in the bone marrow, you see these toddler cells, and they are characterized, you can see the cartoon here, by these granules, because as the myeloblast turns into a neutrophil, it develops these granules. That's part of what a neutrophil does. It has these granules that it uses to fight infection. So here you see the beginnings of these granules, and you see these cells with these granules. It's sort of the hallmark of the disease. APL is defined molecularly by the existence of this translocation. So basically what you have is you have this chromosome 15 that contains the PML gene. And we don't know what the PML gene does, and the only reason that we really care about it at the moment is that it's involved in APL. And on chromosome 17, you have this retinoic acid receptor gene. And we know what these retinoic acid receptors do. They're a group of proteins that function is to bind to certain genes in the nucleus of the cell and promote the expression of those genes and to promote normal differentiation. So what you have in APL is that there's a translocation. So the first part of the PML gene gets attached to the second part of the RAR gene over here. And similarly, the first part of the RAR gene gets attached to the second part of the PML gene, and that is shown here. So you have this translocation where part of 15 is attached to part of 17. And this is an abnormal protein that is an abnormal RAR protein that has abnormal function. So there's going to be a problem with differentiation of the cells. What this protein does, this abnormal protein, is that it goes into the nucleus of the cell and it binds wrongly to the wrong genes or too tight to the right genes. And we're still trying to figure out exactly what it does, but it blocks transcription of certain genes that we want to be transcribed. And there's a block in differentiation, so these toddler cells cannot mature into adult cells like they're supposed to. And it also enhances their self-renewal, so that cell is going to start making more and more of itself. And all of this is caused by that translocation event where part of 15 gets attached to part of 17. APL used to be the worst prognosis type of leukemia to have. And survival is estimated to be less than 1 month without treatment. But since the development of targeted therapies against this PML-RAR protein that is abnormal, APL is now the best type of leukemia to have. And I literally tell patients, if you have to have leukemia, this is the one you want to have. The targeted therapy, and you can see here that, remember those curves I showed you where they were all the people, the probability of being alive was coming down and down and down as time went on? Well, look at these, we divide people into risk categories here, the same way as we do with AML, but these low-risk patients, I mean, these people are, the chance of being alive at 80 months after diagnosis is 100% in this group. So these people are doing really, really well. And the reason that they're doing well is because we have these targeted therapies. And the targeted therapies we have are all-trans retinoic acid, or ATRA, and arsenic.
So how long have these therapies been available to the general population?
It's been in the last couple of decades. I'm going to show you.
20 years.
Yeah, it's about, yeah.
Okay.
Is there some type of, something that prevents cells from running amok, so to speak? Is there some factor that acts as a brake normally?
Right, exactly. So the cell, things go wrong in the cell all the time, and the cell has a lot of protective mechanisms that are designed to fix the problem or to die in a controlled way so that it doesn't perpetuate itself. But the problem is that those protective mechanisms can go awry. And a lot of the genes that encode the proteins responsible for those protective mechanisms are genes that are related to cancer. So what are these targeted therapies doing? Well, again, we don't exactly know what they do yet, but what we do know is that they restore the ability of the normal RAR protein to bind to the DNA, and then they also help degrade the abnormal protein in the cell's degrading machinery, like the garbage disposal, basically. And so these two things allow the APL cell to mature, and also reduces its ability to perpetuate itself. The molecular mechanisms of this, again, are still being worked out. So, yeah.
I have a question. If the survival is less than 1 month, that means you must diagnose it within 1 month.
That's right. And I'm going to talk, but yes, diagnosis is urgent. And people can, unfortunately, die if the disease is not brought to medical attention soon enough, or if they don't receive the appropriate care soon enough.
Is it easy to diagnose?
The typical symptoms are the same symptoms as acute leukemia, and so unfortunately, some of those symptoms are nonspecific. I can just give a personal example that when I was in medical school, I was on my surgical rotation, and one of my classmates, we were all tired. None of us were sleeping, and one of my classmates woke up one morning with some bruises, and she didn't really recall having bumped herself. She went to student health and had blood work checked and was diagnosed with leukemia that day. Positive story is that she received treatment. She actually graduated on time with the rest of our medical school class, and she is a pediatrician with 2 children. So, you know, it's pretty, this disease also sort of holds a soft spot in my heart because of that. These people are really rewarding to treat because a lot of leukemia is very aggressive and very difficult to treat, and these people can do so well that it's a rewarding way to work. So again, to answer your question about the evolution of therapy for AML or APL, we used to just use chemotherapy alone, and outcomes were really not that great. And then in the 1990s and in the early 2000s, clinical trials were done looking at chemotherapy plus ATRA. And that really is what markedly improved outcomes for the disease. And then in the 2000s, arsenic was recognized to be also a very effective targeted therapy for this disease and was started to be incorporated into clinical trials. And actually now in the 2010s, people are looking very carefully at treatment regimens that involve ATRA plus arsenic without chemotherapy. And you know, ATRA and arsenic are actually relatively well-tolerated drugs. They don't really cause nausea. They don't cause hair loss. They're compatible with being an outpatient. And so, you know, this is sort of the way of the future in terms of treatment of APL. And it, you know, when this pans out after it's studied in a thorough fashion, it will radically change the way we treat this disease.
When does the arsenic become poisonous?
It is a, well, yeah, so it is a poison, and that is, frankly, all our chemotherapy drugs are poisons, and any drug, when taken in a high enough dose, is also toxic. And so part of doing clinical trials is, the first phase of clinical trial development is to establish what is a maximally tolerated dose, or MTD, and that is the dose that is safe to give. And then the next step is to look in a phase 2 study, we call it, at the efficacy of that dose. And many drugs fail at that level because at the dose at which they are tolerated, they're not effective. Arsenic is obviously toxic when given in too high doses, but we're able to figure out the right dose to give people that it is tolerated. But there's a lot of joking around our clinic about, my arsenic. And
What's the risk for the children of the pediatrician in later going on to develop APL?
APL is not known to be an inherited disorder. I mentioned that earlier, and these are mutations that are occurring in the leukemia cells themselves. They're not found in the patient's regular cells, and in particular, they're not found in their germ cells, so like their ovarian cells. And so there's no risk to her children to developing that disease above and beyond the risk of that somebody in the population.
And the same would be true for AML?
Correct. And the only exception to that is that in these very rare genetic diseases where blood disorders run in the family, so the Fanconi's anemia patients, for example, where when you diagnose someone with Fanconi's anemia, all the family members have to undergo should undergo genetic testing because it can affect the patient's family members and their children, because that is what we call a germline mutation, so it's present in every single cell in the body. The mutations that are occurring in AML and APL are freak events that occur in that cell themselves and not in the rest of the patient's cells. So they haven't had it since birth. They've probably had it for a matter of months when they're diagnosed. And just one last note about APL. APL commonly presents with bleeding. And there's something called DIC, which you may have heard about, called disseminated intravascular coagulation. And this is basically abundant activation of the clotting cascade and consumption of the clotting factors. So people with DIC can have problems with clotting, and they can also have problems with bleeding. And for whatever reason, the APL granules, these granules in the cells, affect the blood's clotting proteins and can cause DIC. So people can have DIC when they present with leukemia, when they're diagnosed, but also during their treatment for leukemia. As these cells die, the promyelocytes effectively burst and dump all these granules into the circulation, and that can really worsen the bleeding and clotting problem. And so there is this issue of the early death rate from bleeding complications, which has been estimated to be between 10 and 30% of patients. So that's a lot of people in a disease that is otherwise very curable. To have this many people die early before they've really had a chance to even get into remission is where a lot of work really needs to go right now. And that almost needs to happen at a system level in terms of identifying these patients early on and making sure that they get into appropriate therapy before the disease sort of becomes out of control. And I think we need to learn also more about either new drugs to kind of arrest this complication or just other management strategies. Okay, so we're heading to the home stretch, and I'm going to talk about stem cell transplant. What's a stem cell transplant? It's not a surgery. That's a big misconception. What a stem cell transplant is that it consists of chemotherapy with or without radiation, followed by infusion of hematopoietic stem cells into a vein. So these are the cells that we're talking about, and we get them from somewhere, which I'm going to talk about, and then we infuse them into the patient's vein through an IV. And once they're in the bloodstream, the amazing thing is that these cells find their way to the bone marrow, and that's that homing that we were talking about. These cells have these mechanisms for finding their way to the bone marrow where they set up shop and grow, and they regenerate the person's bone marrow that has been ablated by this chemotherapy.
Is there a reason why you choose a vein as opposed to an artery?
Yes. So when you infuse something intra-arterially, the first place it goes to is the capillary, and things can get stuck in the capillary. So almost everything we infuse through a vein because it gets delivered more systemically because it goes to the heart and then out to all the organs of the body, as opposed to just the capillary of whatever artery you're, if you're injecting into a kidney artery, it would just go to the kidney and then it would get stuck there. Okay, so I want to just talk about some terminology. So how is a stem cell transplant different from a bone marrow transplant, right? Because a lot of people have heard the word bone marrow transplant. So basically, it's two terms for the same thing, effectively. And the difference really has to do with how we get the stem cells out. So it used to be that we only did bone marrow transplants, and that is the older term. And what we would do is we would take a donor to the operating room, put them under general anesthesia, and then do bilateral or both sides of the hip bone serial bone marrow biopsies, like 50 on each side. And that's why they had to be under general anesthesia. And we would get out the bone marrow, which contained the stem cells. And then we would use that product and sort of purify it and process it, and then infuse those stem cells into the patient. We now know that we can use a medicine called Neupogen, which is a growth factor, to make the stem cells that normally live in the bone marrow come out into the blood. And then we're able to put in a venous catheter, which is like a large IV, and the patients lie in a bed, and they're hooked up through this catheter and some tubing to a big machine. And this is very similar to dialysis. If anybody knows anything about dialysis or anyone who's on dialysis, basically blood flows out one side of a catheter into the machine, and the machine removes the stem cells that have been made to come out from the bone marrow into the blood, and then it gives the rest of the patient's blood back through the other side of the catheter. And so blood is continuously circulating through the machine, and the stem cells are removed. And this process takes about 4 to 6 hours. It's relatively non-invasive, other than having the IV in, but there's like no operating room, there's no anesthesia, there's none of this. And it takes about 4 to 6 hours, and then when we get out the stem cells at the end, we either freeze them away or infuse them fresh into the recipient. So this is not really a bone marrow transplant. We're really calling this a stem cell transplant. And effectively, a bone marrow transplant was a stem cell transplant. We were just getting it out of the bone marrow directly, but what we were really looking for is those stem cells. So stem cell transplant is the more inclusive term, and it's sort of the modern term that we use, although, again, people still use them interchangeably. Currently, the vast majority of our transplants are done this way. Although there are certain times when it is done this way, particularly for certain disease indications, and that gets a little technical, but the majority of them are done this way. More terminology. Autologous transplant versus allogeneic transplant. There are two kinds. So autologous means derived or transferred from the same individual's body. So this is when we are using the patient's own stem cells to do the transplant. Allogeneic is another word for donor transplant. So this is being genetically different, although belonging to or obtained from the same species. So we're using another human being, and we're getting the other human being's bone marrow stem cells and infusing them into the patient. So that's a donor transplant. And that's the one that most people are probably familiar with when they think about stem cell transplant. But there are two kinds. And again, which one we use depends on the disease type and depends on the patient. They are very different. I impress upon patients all the time that they're very different in terms of their philosophy, their rationale for what we are doing when we are doing it, in terms of, again, the diseases and the disease scenarios that we'd be using them in. And also, they differ dramatically in their level of risk associated with the process. So in autologous transplant, or transplant from yourself, the goal is to administer very high doses of chemotherapy. And the idea is that if some chemotherapy is good for your disease, more chemotherapy is better for your disease. But the problem with very high doses of chemotherapy is that healthy bone marrow cells are destroyed too. And if all you did was to administer very high doses of chemotherapy, the patient would never recover their bone marrow and they would die of bone marrow failure. So what we do is we administer stem cells to rescue the body from the high-dose chemotherapy. So first we remove the patient's stem cells, freeze them away. Then we give very high doses of chemotherapy, and this is the cancer-fighting part of the process. It's the very high-dose chemotherapy. And then we infuse stem cells to rescue the bone marrow and regenerate the bone marrow after it's seen this very high-dose chemotherapy. And this really isn't doing much at all. This is really like the supportive care after the very high-dose chemotherapy, which is the cancer-fighting part of the process. So schematically, we give the chemo first, and then we give the stem cells. And after the chemotherapy, the blood counts, the white blood count, the red blood count, the platelets all fall, and there's this period of low blood counts. And then eventually the counts recover, and when the counts recover, it's those new bone marrow stem cells that were infused in that have found their way to their bone marrow and set up shop and regenerated the bone marrow. And the toxicity, the side effects of this regimen or this approach come from, number one, the chemo, because that has side effects, and number two, the low blood counts, because when your blood counts are low, you're at risk, as we've said, for infections and fatigue and the risk of bleeding and bruising. So those are the risks that are associated with autologous or self-transplant.
So the stem cells aren't malignant themselves, and there isn't a risk?
That's a really good question, and that's exactly why it's only applicable in certain disease scenarios. Because you can imagine, if you had a disorder of the bone marrow stem cell, you wouldn't want to give yourself back your own stem cells. And similarly, even if you have a disorder that's not a stem cell disorder, you do worry that the stem cell product is contaminated with your leukemia cells. And people have done a lot of work trying to purge or clean the product and try to remove every last leukemia cell, and we look for them and we can't find them, but we know that they're probably there in a certain percentage of people, and that's what may be part of why the process isn't for everybody. Okay, so now donor transplant. So autologous transplant is chemo, and that it really is another word for high-dose chemotherapy. But donor transplant really works in two ways. Number one is it replaces the bad bone marrow and or the patient's cancer with good bone marrow, somebody else's healthy bone marrow. But it also uses the new immune system, the donor's immune system, to recognize any remaining cancer cells that the chemotherapy didn't get rid of as foreign and attack them. So donor transplant really is a type of immune therapy. So schematically, we give high doses of chemotherapy to kill cancer. So there's some disease activity here where we're getting rid of some cancer cells. And then we infuse the donor stem cells to regenerate the bone marrow. And those donor stem cells recognize and kill cancer. So it's really a two-pronged approach to treating these diseases. The problem is that in addition to the donor stem cells recognizing the patient's leukemia as foreign and attacking the leukemia, it can also recognize the patient, the host, as foreign and attack the rest of the patient. And that creates a disease called graft versus host disease, which we abbreviate GVHD. And that is essentially an autoimmune disease because it's the recipient's new immune system that's attacking him. And that can affect certain organs in particular. It can affect the skin, the liver, and the GI tract, but it can affect any organ in the body. And unfortunately, it can be pretty severe and it can be fatal. And at the moment, given our current scientific knowledge, we're not able to separate graft donor stem cells versus leukemia and graft versus host. We think, unfortunately, it may be the same cell that's doing both of these processes. If it's a different cell, we can't figure that out yet. And so we actually tell people that we like to see a little bit of graft versus host because it means that their new immune system is active and doing something. And maybe when we see a little bit of graft versus host, we're getting a little bit of graft versus leukemia. And that's really what we want to get out of this whole process. But we don't want to see so much graft versus host disease that it becomes more of a problem than we've fixed. It's quite a complicated balancing act of how active to let the immune system be. So schematically, again, we give this chemotherapy and then we infuse the stem cells. The blood counts go down as a result of getting chemotherapy, and then the blood counts come up, and when they come up, it's that new donor immune system, the foreign immune system, that's taken hold in the bone marrow and is regenerating the bone marrow. People's blood type actually changes during this process if their donor has a different blood type than they do, because all their blood and all their immune system is being completely regenerated. Once they have a new immune system, though, they're at any time from here on forward, they're at risk for graft versus host disease, because once you have a graft, you can have graft versus host. So the toxicity of this approach comes from the chemo, and it comes from the low blood counts, but it also comes from graft versus host disease. Now, in order to prevent graft versus host disease and treat graft versus host disease when it happens, we give immune suppressive medicines to suppress that new immune system and prevent it from causing too much graft versus host disease and becoming active too quickly. But the problem is that those medicines also increase the risk of infection. So in addition to graft versus host disease, we have the risk of infection, and those are the two major reasons that stem cell transplant is difficult and is riskier than a transplant from yourself. Nonetheless, it is necessary in certain situations where we know that these types of leukemias and other blood diseases are not curable without this approach. We wouldn't do it if we didn't have a better option, but unfortunately, this is often the only way to cure these diseases. I want to briefly, sorry.
Is the timing between the chemo and the stem cell transplant important?
It is. You don't want the stem cells to be exposed to any chemo because they're young and naive stem cells, and we don't want to damage them. They're the new immune system. So we give the chemo, and then we usually wait a couple of days in order for the body to metabolize the chemotherapy and get rid of it, basically pee it out. And so there's the chemo is still doing its damage on the cells that it's affected, but there's no more active chemotherapy circulating in the body, so the cells are not exposed to the chemotherapy.
And do you also test to see whether the cancer's still there, or?
In the stem cells?
Well, no, in the patient originally.
So we're doing the transplant because we believe, or we know that there is cancer there. Yeah. Right.
I have a question. I thought that people were matched with their donors.
They are. And that's something called an HLA match, which stands for human leukocyte antigen. And we often call that a tissue match. And it's certain proteins that exist on cells that are involved in the immune system's ability to recognize self versus other. And those are different proteins than blood type proteins. So you can be an HLA match with somebody and still have a different blood type. But they are matched, and that's what I'm going to get to. Yeah, so we do need a donor to be matched for those specific types of proteins that are expressed on cell surfaces. And without going into more detail, those proteins are involved in the ability of the immune system to recognize self versus other.
So I guess you'd have worse graft versus host disease if you didn't match.
Exactly. So I'm going to get to this in the next slide. But right, a donor that is perfectly matched should have less graft versus host disease than a donor that is less perfectly matched. Unfortunately, because graft versus host, we can't separate that from graft versus disease. There's some advantage to having there may be some advantage to having a less perfectly matched donor. We want to see a little bit of graft versus host, but generally we opt for the best matched situation possible. So that brings me to my next slide, which is just a word about stem cell source. So when we're looking for a donor for a patient, who are we looking for? Our first choice of donor is a sibling donor. So that is a sibling with the same mother and same father. And each sibling has a 25% chance of being a match, which means they have a 75% chance of not being a match. So we sometimes get lucky. We have somebody with one brother or sister, and they're a match. And then we have patients where they have 10 siblings, and none of them are a match. So we just have to test them. If we don't have a sibling match, the next place we go to is the International Registry of people who've volunteered to be bone marrow donors. And we look for what we call a 10 out of 10 match. And at this institution, we will also do a 9 out of 10 match if that's what's the only donor that's available. We do not typically do less than that. And then so for Caucasian people, there's about a 70 to 80% chance of finding a match in the registry. But for other groups, other ethnic groups and other populations, it's not as easy. Because they're just underrepresented in the database, and you're looking for somebody that maybe more often than not has the same background as the patient, although again not nearly all the time. So if we can't find an unrelated donor from the international database, then we have two other options. And those are umbilical cord blood and a half-matched donor. And at the moment, these approaches are on the verge from becoming what I would call experimental to becoming kind of part of the standard of care, but definitely I think not preferred at this institution to either of these options if they're available. And then I'm going to end with this slide from bethematch.org. And so I just want to end again on behalf of our patients by putting the message out there that stem cell transplant does cure disease and it does save lives. And a lot of us on this campus are working very hard to make that happen for patients of all ages. And so I would encourage people to go into the registry. All it takes to get into the registry is a cheek swab. You don't even have to have a blood draw. And you never know, you may be called to be somebody's donor and hopefully help save their life. So I'm gonna end there, and I have 3 minutes for questions. Go ahead.
I feel like I have a real dumb question, but why is stem cell research such a highly charged ethical and political debate?
Yeah, I think that there certainly is a lot of, and this is, so there's stem cell research. There are a lot of different kinds of stem cells. And I think you've probably heard a little bit about that in previous lectures. But I think the one that people get really agitated about is the embryonic stem cells, because there's this potential for cloning, and that makes people nervous. And you know, I guess from a science point of view, you know, we're very regulated, and I personally, I don't really see it, but I think that that's the other side of the argument, that there's potential for abuse of these technologies. I don't think the controversy really exists for hematopoietic stem cells, which all those cells can do are regenerate the bone marrow. They can't really regenerate anything else. So there's, I guess, less potential for abuse.
How often does cancer therapy cause leukemia? You know, if it does pretty often, can't you take the person's stem cells before that therapy?
That's an interesting idea. Unfortunately, it's not that common. Well, fortunately, unfortunately, it's not that common. So I think it depends on the regimen that's used for cancer treatment. You know, ballpark figures are certainly in the single digits in terms of the percentage of people that go on to develop leukemia. It's probably less than 5%. And so I think it would be difficult logistically to harvest everybody's stem cells when the vast majority of people won't need it.
Is it feasible?
It would be feasible. It's feasible to harvest anybody's stem cells as evident.
For a long time.
And right, and we don't have a lot of great data about use of stem cells after, you know, 5 or even 10 years. There's not a lot of data about how effectively they're preserved. So it's not like a truly long-term solution. But most of the secondary, well, many of the secondary events happen within that time frame. So some of them, though, are later, 10 to 20 years.
If I'm understanding, like the myeloblast, that's like one cell, you know, it starts with one cell that has the problem, and then that one cell is enough to just proliferate to cause. Okay.
That's right. And sometimes when we're looking to see if we have remission, we see some myeloblasts, and we say, are those normal myeloblasts or abnormal myeloblasts? Because there are normal myeloblasts around. But the whole thing starts with one cell where one mutation happens and that cell proliferates. Yep.
I think you were talking when you were talking about acute myeloblast leukemia, that in the phase 2, the consolidation phase of treatment, you can either treat again with chemo or with stem cell transplant. what are the options there? And do you treat with the same sort of protocol of chemo that you did the first time?
Yeah.
Use different drugs the second time around?
So the first phase is induction, and that's basically, for AML, it's typically 7 days of chemotherapy. And that's a pretty set regimen. We pretty much give it to most people with the disease. And then the decision comes once they're in remission. And it actually can take a few weeks to get that cytogenetic information back. So risk stratifying a patient can take a while. So we don't have that information up front. So we sort of treat everybody the same up front for the most part. And then we have to make a decision once they're in remission about how aggressive to be with our treatment. And I would say that in broad strokes, for many of the people that have favorable risk disease, we will use chemotherapy alone. And there have been studies looking at what is the best chemotherapy regimen to give for consolidation, and there is a sort of accepted standard for that. And then for the unfavorable risk patients, those patients need a stem cell transplant to be cured. So we're going straight to donor stem cell transplant or allogeneic stem cell transplant as soon as we can. And then for the people who are in the intermediate category, the expression I've used is dealer's choice. I mean, there's data to support a lot of different approaches in that circumstance. And if you look at national guidelines, they list everything as an option without a clear preference. So that ultimately comes down to availability of a donor, patient preference, a lot of discussion between the patient and the physician about their preferences, and it can come down to personality in terms of how much do people want to gamble that they will be cured by chemotherapy alone or not cured by chemotherapy alone and require a transplant later versus just going for a transplant up front because it's their best chance of cure. And there are risks and benefits to each of those approaches, and it's a very complicated discussion.
Is the success rate for the intermediate level as good or equal to the ones at the low level?
It's intermediate.
That is to say, after the stem cell transplant. Is everyone cured after stem cell?
No.
Okay.
Stem cell transplant is not a guarantee of cure. So yes, the outcomes in general are better with intermediate risk than with poor risk disease. I guess the question, though, is whether those patients need it, because everybody would prefer to be cured by chemotherapy alone if they could. They wouldn't have the risk of graft versus host disease that lasts a lifetime and the risk of dying as a result of transplant if they didn't need it. So the question is, how confident are you that you can be cured by chemotherapy alone? And if you think you have a good enough shot, then you might try it. And if you're not sure, then you might want to go to transplant first.
Is the standard of care still a month of isolation following the stem cell transplant?
The isolation policies have changed a lot. And I guess we call it restrictions because, I mean, patients go home. So patients are in the hospital for about 3 to 4 weeks for a transplant. During that time, they can't leave the hospital, but they can have visitors. And so we don't restrict, they're not like isolated and kept by themselves. When they go home, they have restrictions in terms of particularly being around large crowds of people because people have viruses and we don't want them to get sick because they're on immune suppression, and other restrictions just having to do with essentially preventing infection for the most part. And those are gradually lifted over time.
Can a transplant be repeated or can you do it done once?
It actually can be repeated. It's the rare patient that really is a candidate for that approach because they have to be able, number one, to get back into remission, which is not always easy. And number two, they have to essentially be free of graft versus host disease because it's hard to give a second transplant when somebody's already suffering from graft versus host disease. So it requires just the perfect constellation of circumstances, but it's not a never situation. I think I might have time for one more question, and then I think I have to take questions up front, but they're going to wrap up.
Were the telomeres discovered by working with one of these diseases you talked about tonight?
Actually, they were discovered by working in, I forget the name. It's a very simple organism. Tetrahymena. It's like an organism in a dish. Okay, I think that's all the time I've got. I'm happy to answer questions at the front.